This is the US epi curve, and you can see that cases are starting to increase in terms of national level data. An increase of 8% this week over the previous 2 weeks. The places where it's particularly, well, let me show Alabama's map first. So you can see we're still moving in the right direction, although there looks to be a little bit of a plateauing, but still, all of the markers, all of the metrics that we're continuing to track, we're still doing pretty well in Alabama, and not too far off on vaccination status compared to the nation, with about 29% of folks having received one dose. But the real problems, though, are that viruses don't respect state borders. This is Michigan's epi curve, which is really startling. 56% of their isolates are now the B117 variant. And you can see that they're hitting case numbers higher than they experienced even back in December. So indeed, if you look at the US map, so you can see the hotspots. And there's Michigan, Minnesota, some places in upstate New York, or in western New York and Pennsylvania. But Texas is concerning. So again, we can't necessarily keep this virus away from our borders, especially as more and more travel is occurring now. I guess the bottom line here is the mitigation measures that we've been using. We continue to need to rely on those, but probably the most important message here is vaccinate, vaccinate, vaccinate.
So this project was funded as part of our Back of the Envelope initiative. And I did this in collaboration with Mayo Danilo was the primary person. Jeff Foster was the other big data collection person on this. And of course, all this occurs under the rubric of the School of Medicine, access to the medical records and what have you. Hence, Jeff Curtis and Ken Sagg out of rheumatology were instrumental in helping me gain access to the data. So let's see. So one of the big questions that came out during the pandemic is patient satisfaction with telemedicine. And I'm not going to use the word comparable, non-inferior to other mechanisms. And the reason this came up as an issue, of course, is we stopped seeing people in the clinic, and many of our patients were able to use telephone techniques, but not necessarily video visits. So we actually checked all three modalities: in person, video assisted, and pure telephonic. And rather than say comparable, the goal we're looking for here is something called non-inferiority. And this is actually a very specific group of statistical tests that try to demonstrate. A lot of this comes out of the pharmaceutical world, as you can imagine, hence the rheumatology group who does a ton of pharma testing, and essentially seeing if we can find better, cheaper alternatives to current products in the marketplace is where the non-inferiority testing model comes from. So as you all know, and this is sort of written for a lay audience, I apologize, but COVID-19 required that we change our modalities. Many people with rheumatoid arthritis in particular get routine encounters with their physicians to check the progress of the disease, ensure that any drugs that they're taking are not compromising their system. A lot of people take anti-inflammatories, essentially immune suppressant drugs. And so as you can imagine, this population taking a lot of drugs that suppress their immune system could be potentially vulnerable to COVID. So there was a lot of worrying about how best to tend to their day-to-day care. And one of the questions was, can we do what we've been doing in person over the telephone? Importance in terms of the business model was telemedicine was greatly increased as a mechanism by which we were allowed to be compensated. And therefore, it really opened this up in ways that we hadn't previously been able to do because of the compensation issues. And I don't know about the rest of you, I actually had telemedicine for my orthopedic procedures this month, which I'm not impressed by. So for one reason, I will tell you it is dramatically inferior to actually having my doctor look at my knee and try to figure out what's going on with it. But that's me, and this is the rest of the world. So we did parallel groups. We randomized people into the trial, which was fairly nice that we were able to do this. And we tried to figure out which interventions were amenable to different parts of our randomized audience. Our preferred mode was video visits. We were hoping that a lot of the audience would be able to use Zoom and the like. That was not as prevalent as one might have thought, especially this was done almost a year ago at this juncture, and we did it for 3 or 4 months. But this is the early days, and many people were switching into remote modes of communication and hadn't yet mastered Zoom. So this again was the multi-specialty part of the School of Medicine. We had family medicine, rheumatology, and cardiology were all involved. We did this with established patients. In other words, we were doing this for routine care, not the new patient admissions or for emergent conditions or those sorts of things. These were essentially routinized care. In rheumatology, a lot of times, if this is arthritis, this is like counting affected joints, looking at people's skin for lesions, those sorts of things. But we were trying to do that by phone. We used the CAPS survey. We can have Paul Wolf come on and explain how this whole thing works someday at some great length for those of you who don't know. UAB has a rather unusual method of using the CAPS scores. Because most patients like to get care, it's not unusual for most of them to give 9 or 10, the highest available scores. So UAB essentially says if the patient gives you a score of 9 or 10, that's satisfactory. Everything else is unsatisfactory. I might take exception to that scoring system, but that's what they use here. And so that's what we go with. This were all visible on your screens. You would see the means by which we started with about 2,800 participants. We invited 1,300. And by the end of the day, through a variety of screening, we found that about 269 of them were actually eligible to be randomized into either our video arm or our telemedicine arm. And the rest of that 1,300 essentially served about 1,000, in other words, as controls, 1,010. And so we use those 1,010 as our baseline to compare against. We were very successful in oversampling on key minority groups, African Americans and women. Because of the nature of this chronic disease, they tended to be slightly older than the general population. In our inferiority testing analysis, we compared phone only to other modes, and I'll go into the more discrete presentation. There's the descriptive statistics, that's for the paper. And apologize, I'm trying to move along fairly quickly because I know you've got a lot to get to. Here's sort of the payoff pitch. And as you can imagine, the vertical gray line going up the middle is the one that if any of these features were to, any of the horizontal bars were to fall outside of it, would have meant that there was a significant difference. We're very fortunate. The goal of non-inferiority testing is the opposite of most statistical tests. We want all of our bars to overlap, indicating that the modes of care we were delivering were non-inferior, adjusting for these various features. And the good news is most people favored telemedicine over video, which we thought was rather interesting. That the video analysis did not fare well. A lot of people felt it was intrusive. There were lots of in our open-ended comments, there's a fair amount of paranoia, to be honest. We also don't think that people like looking into their home. Paul Wolf and I did a fairly significant study for our NCIAD, and we found the same sorts of comments coming back in that population, that they simply didn't like us looking into their households in many ways. And so telemedicine, or excuse me, video telemedicine is less preferred to phone, and this is the second study we found this. So it's sort of interesting. Earlier in the conversation, before many of you got on, we were talking about using the different backgrounds. I wonder if we allowed patients to automatically, without having to master Zoom, be able to put up backgrounds that just showed them, if that might increase the preference for video over telemedicine. So the big meaning is, at least in the short term, and again, I have to emphasize the short term, I think many people were thrilled to be getting any form of care at all at this point, particularly for their chronic illnesses. Being able to renew their prescriptions and those sorts of things was non-trivial. And so they were very happy in the short term to be able to use telemedicine, in particular telephonic, as a mechanism for maintaining their continuity of care.
UAB asked me to give an update to herd immunity, or, as I mentioned to them, that maybe we shouldn't be calling it herd immunity anymore. Are you guys seeing the Word document with the 3 colored figure? Yeah, okay. There's a researcher out of Harvard who's now calling it the return to normality rather than herd immunity. And it's really because the term herd immunity for epidemiologists has a very specific meaning, and it really means what we would, the level of immunity we would want so that the virus spreads not at all. So it's down to 0. And never would we ever recommend that herd immunity be achieved through infection. So people are kind of questioning the terminology. And so now return to normality. I was on another call this morning where somebody called it community immunity. If there would be other terms that could be suggested, but basically we know that roughly 70% of the population needs to have some level of immunity in order to slow the spread of cases based on the R0. And I presented that a few months ago. What we didn't know before, but we know now, is that it's likely that there's a loss of immunity in people that had a COVID infection versus those that were vaccinated. I'm not an immunologist, nor a virologist, nor a vaccinologist. So I don't understand the science. I've read the papers 2 or 3 times and I still don't understand the science. But I can look at what the papers suggest and make assumptions based on that. So what I assume in these models is that for those folks that are that have had a COVID infection, but it never had a positive test, I assume that they have less durable immunity than those that had a COVID infection with a positive test, and less durable immunity than those vaccinated. It assumes that immunity fades after 6 months for those that were in the untested group, and by 12 months, basically anybody that had a SARS-CoV-2 infection is completely susceptible to reinfection. So that's how this model differs from the models you've seen before. You can see the yellow widens now. And basically, to me, the most interesting thing about all of these scenarios and playing it out, and I can't remember if I still have this open in Excel, but if we actually look at the underlying data, oh, maybe I can't do that. If we were to take an assumption and say, okay, well, what would happen if everyone stopped getting vaccinated today? What would happen? Oh, I can't show you, sorry. I can just tell you in words. By November, by Thanksgiving, we would be in the exact same boat we were in November of 2020. So if for some reason Alabamans say, okay, we've got 1 million people vaccinated, we're good and we're done, and we don't want to get vaccinated anymore, next Thanksgiving would look a whole lot like last Thanksgiving. So we really need to continue the push. In my opinion, we need to push 16 to 30-year-olds. If I were to roll out the vaccine, I would be targeting all kinds of campaigns geared right at the 16 to 30-year-olds, because I think they're the most important demographic at this point in time to vaccinate. And once the 12 to 15-year-olds, once the FDA clears them, I would say the 12 to 30-year-olds are the demographic that are absolutely critical to vaccinate. The other thing I shared yesterday, if there's any question about whether or not the vaccine works, here in Alabama, if we compare COVID cases by age from December to March, the 75-plus-year-olds have experienced a 94% decrease in COVID cases. The 0 to 19s are only at 87%. So cases are decreasing the most among the groups that were earliest to be vaccinated. So this is to me, it's really exciting news. It's looking good in Alabama, but the caveat is we have to keep the foot on the accelerator. There are going to be setbacks in public health. The J&J vaccine has people very concerned, but you're talking about 1 in a million that are going to get a blood clot with the J&J vaccine. It's something like 1 in 4,000 if you've had a COVID infection. You get 10 times the risk of having a blood clot if you're infected with COVID versus you have the vaccine. That's a study that came out of Oxford early this week. So those are the types of messaging that we have to keep giving the public. It's good the FDA is checking into it. That's what the FDA is supposed to do. But at the end of the day, the vaccine is still far safer than getting COVID. And if we don't continue to get people vaccinated, we're going to start seeing COVID cases again in the fall. So to me, that's the biggest takeaway from the community immunity, since herd immunity is really not the proper term.
By now, this is a familiar set of slides that you've seen. If we were a business and we were looking at this from a business perspective, we would say that we're in a declining market, which is a good thing from a health standpoint, is that the number of case interactions that we're experiencing are declining. They have not yet reached the levels they were back in August of last year and so forth, but they are declining. Our investigators are presently working at about 65, somewhere between 52 and 68% capacity at the moment. So we have quite a bit of slack capacity, and I'll talk about what may be some plans in dealing with that here in a minute. So here are billable cases. They're down a little bit for the month of March, cases per day, but they're not as low as they were. The positive cases you see in December and January are because the student population graduated at the end of the fall semester, so we had fewer student investigators, and we're building back up in January and February. You can see that the average is about 160 per day of billable cases. And then our letter productivity, number of letters that we're mailing out for people to contact us, are a pretty good indication of the infection rate in the state. It's gone down quite a bit. Our letter writing has dropped off remarkably. We have a skilled workforce in terms of the case investigators and contact tracers, and we've been in negotiations with ADPH about what we might be able to do with that trained workforce. We have some choices, of course. One of those choices is layoffs, and unless we can figure out and negotiate another revenue path, another productive use of their time, that's exactly what we'll have to do. But we're in those discussions as we speak. What's been proposed is that we would dedicate some of our teams of investigators to assisting residents of the state in making vaccine appointments through whatever means possible that we could use. Collect information from them about what is needed to make an appointment and communicate that to them, and so forth. That's still in the developmental stage. We have some technological hurdles to overcome. They're not insurmountable. They're actually quite easy. The biggest hurdle is getting ADPH to approve this change and the new budget for so doing.